Okay, people are quietening down in anticipation, so it seems like a good time for us to kick off. I'm sure there are a few stragglers coming in, but we will welcome them happily. Thank you all so much for being here. My name's Kate Donald. I'm the head of office for Oxfam International here in Washington, D.C. My job here today is a very easy one. It's just to welcome you all and thank you for being here. I think this is a really important discussion at this particular time when we know there's lots and lots of high-level discussions going on about what is the future of development finance and how do we finance development and climate action and the public and social goods that we so desperately need. We know those conversations are happening in the context of the Brazilian G20 presidency. We know they're happening at the World Bank itself, at the World Bank Group, and in the MDB, the Multilateral Development Bank system more broadly. And we know that they're happening at the UN too, especially in the context of the Summit for the Future and the Financing for Development Summit, which will happen next year in Spain. So it's a really important time for us to analyze, how do we move forward and what are the best approaches for people and for communities for us to finance the public goods and the type of development that we need. I won't spend a lot of time here introducing Oxfam. Hopefully many of you know who and what Oxfam is. We're a global organization that works on the fight against poverty and inequality worldwide. I want to give particular thanks to our colleagues at Oxfam America, who have helped us and advised us on putting this event together. And I also want to thank George Washington University for hosting us in this space, which has a very nice view. It's a little bit obscured in the corner, but those of you who haven't seen it, please feel free to take a look. And now I'm going to pass over to our wonderful moderator and host, Maaza, who is another reason I need to thank Oxfam America, because she's been loaned to us from Oxfam America. We knew she was exactly the right person to host this discussion, having been involved in a podcast that Oxfam did about these very same issues. So for those of you who are looking for more content in your podcast feed, you can go and look that up. Over to you, Maaza. Thank you, everyone.
Thank you. Thank you so much, Kate. And hello, everybody. It's so nice to see such a lovely turnout here today. Is the microphone good? Can everyone hear? Okay, wonderful. All right. So you know why you're all here. You're here to join us in this wonderful panel, Public Health or Private Wealth. Over the next 2 hours, and in this backdrop of rising inequality and cost of living crises around the world, our great panelists will explore fundamental questions about the appropriateness of investments in private for-profit hospitals in the Global South in the name of universal health coverage and poverty reduction. So just to set the scene a tiny bit, currently half of the world's population is denied access to even the most essential healthcare. In response to this, actors like the World Bank are advocating for greater inclusion of the private sector in public service delivery in low and middle income countries. But organizations like ours, like Oxfam, argue that there are some critical outstanding risks with this approach. So just to put things simply, healthcare privatization, and many of you know this, forgive me, but I will still lay it out for those who don't. Healthcare privatization is a policy of transferring the provision of public services to private individuals or companies. Healthcare financialization refers to the transformation of health provision into financial investments and the subsequent involvement of financial actors in this sector. So our panelists will be examining recent trends in both privatization and financialization, as well as looking at the impacts of private sector involvement, including through private equity funds in US healthcare, to understand what lessons may be here in the United States for the rest of the world. In the last 30 minutes of our 2 hours together, we will turn to you, our audience, and for any questions you may have for our great panelists. We would also invite you to tweet. I don't know if people still tweet, but to X or to tweet about this event. I'm not sure if we have a hashtag that we're using, but if you are sharing about events that you attend in Washington, D.C., please feel free to share on social media. I can see we have one of our social media pro colleagues back there. So yeah, so hopefully we'll get some social media on this. So please do go ahead and share. The event is being recorded, but not live streamed. So we will be hosting this on the Oxfam website after the fact. So now it gives me the great pleasure to introduce our amazing panelists, and I'm really honored to be up here with all of them. Please be patient with me. I'm going to introduce all of them at the start just so we don't break up the discussion as we go. And I'm going to try and do credit to like their amazing, if I were to read out like the entire bios for everyone, that would be the 2 hours. So, but I will try and do a little bit of credit to their amazing bios. So first, we have an award-winning journalist, Gretchen Morgenson, who last year published a prize-winning book, which we were hoping to give out to the 41st people. But those of you who did arrive early, I hope you gave your addresses and you'll get those sent to you. The book is These Are the Plunderers, How Private Equity Runs and Wrecks America. And, you know, Gretchen, I didn't realize you were a former stockbroker. Gretchen is a former stockbroker. She's now a formidable author and journalist, and she won the Pulitzer Prize in 2002 for her reporting on Wall Street, which I've seen everywhere being described as trenchant and incisive. We're so excited to have you here with us, Gretchen. Thank you for coming. Representing the World Bank's International Finance Corporation, we're pleased to welcome Raju Narayan. Raju is a global sector specialist in health and has over 34 years of experience in healthcare sector management, operations, development, and design. When I met him, I thought like child labor, because if you've been doing this for 34 years, I was like, we need to check his ID. Yeah, good. Yeah, good genes. He has worked in tertiary care hospital operations in Singapore, India, Vietnam, Australia, and the Middle East. Thank you so much for joining us today, Raju. So our next panelist has come to us all the way from India, where he works as a public health physician and the national co-convener of the People's Health Movement, India. Dr. Abhay Shukla has worked on public and community health for the last 35 years. So he's beat you by a year, playing leading roles in implementing national and state level community monitoring, planning of public health services, as well as the processes very important for developing the National Patients' Right Charter. Abhay specializes in transnational investments in the Indian healthcare sector, the corporatization of healthcare, and regulation of the private healthcare sector. He also snuck into my ear when he arrived that he now is also on the National Human Rights Commission core group for health in India, which is critical to our discussion today. We're really so happy to have you. Thank you, Abhay, for joining us. Of course, I'm very happy to introduce my fellow East African who's sitting here next to me. Dr. Mercy Nabwire is currently the treasurer of the Kenya Medical Practitioners, Pharmacists, and Dentists Union. Mercy is an influential leader in the Kenyan health sector, advocating for the rights and welfare of doctors and other health workers, especially during the height of the COVID-19 pandemic. It's really nice to have you here. Karibu sana, Mercy. Thank you for joining us. And our final panelist is Anna Marriott. Anna has led Oxfam's health work for the last 17 years, focusing specifically on issues of health justice and access. During that time, she has tracked and analyzed the policies and spending of development institutions, particularly in relation to the growing promotion of for-profit actors in healthcare in low and middle income countries. Anna was also the policy lead for the People's Vaccine Alliance, which is how we met. She was there during the height of the COVID-19 pandemic. Last year, Anna published a seminal report, and actually, I don't know if we have copies of, do we have any copies? No, but please look it up online, an amazing report called Sick Development, How Rich Country Governments and World Bank Funding to For-Profit Private Hospitals Causes Harm and Why It Should Be Stopped. A sister report launched by other Oxfam colleagues at the same time takes a deep dive specifically into IFC's health investments in India. Anna, we're looking forward to hearing from you about both of these great reports. And before launching into the discussion, I'll introduce myself. My name is Maaza Seyoum. I've worked on the social determinants of health for almost 20 years. I'm older than I look, I think. Yeah, so it's been a while. I'm now, as Kate has said, in Oxfam US's economic and racial justice team, where among many other things, we're doing some really exciting work around global economic change and alternatives to neoliberalism. And as Kate has mentioned, we do have a great Sikh development mini podcast, so please do look for that. That's part of what I was doing with Oxfam International, and I'm basically just looking forward to this great discussion today. Before we get started, please give a round of applause to our wonderful panelists to welcome them. Thank you. Thank you. And thank you for your patience with that intro. I wanted to make sure we got that out of the way. So now, Gretchen, I would like to start with you. So if you could help us just set the scene a little bit. You know, our focus for this event, as Kate has said, is the role of development funds going to for-profit healthcare in the Global South. And one of the major ways that this is done is through investments in private equity funds that then go on to invest in for-profit hospitals and clinics. So as I said when introducing you, you recently published that amazing book, which details the growing ownership of public services, including health, in this country by private equity firms, and how their model of investing impacts public service users, so all of us. I was wondering if you could, because it really does, your book reads as a cautionary tale. If you could describe what the book is intended to warn us about, especially when it comes to health.
Well, thank you so much, and thank you everyone for coming. This is such an important topic, and I'm really, really glad that it is at the forefront of these discussions. I think the headlines are with us. We're seeing a lot more discussion in the news about private equity and its role, particularly in healthcare, which I think is extremely pernicious. Private equity is really the old leveraged buyout crew who sort of splashed onto the scene in America in the mid to late 80s. And R.J.R. Nabisco was the big transaction that everybody remembers. Barbarians at the Gate was a wonderful book that chronicled that transaction. We fast forward to now, and the barbarians are not at the gate. The barbarians are at the controls. And so what has happened over these decades has been a sort of growing acceptance of the private equity business model, which is the kind of private equity business model I'm talking about. And I think that we all really focus on, or should focus on, is the use of heavy debt to purchase companies, take them private, and then make them more efficient, quote unquote. This usually means by cutting costs, firing employees, cutting corners, and then selling them 5 to 7 years later, hopefully at a profit. So in my view, this business model is unsustainable for a couple of reasons. One is the heavy use of debt, which just makes the company that is being purchased, that it has to struggle under this debt load. It makes it that much harder for it to really achieve, the goals that the company had when it was taken over. And the second unsustainability aspect is the short time frame. And so you have 5 to 7 years where you need to, quote, turn the company around or make it more efficient. This is a very short-term time frame. And I think we all well understand what happens when you have a short-term mentality about running companies. And so one of the reasons why I co-authored this book now is because these deals have been happening since the 80s, pretty much nonstop, a couple of, economic hiccups in between there. But we now have enough longitudinal data, enough long-term academic studies that really show the impact that these firms and the business model creates. And so when you move it to healthcare, that's when you're starting to really make a difference, life and death difference for people who are the customers, the patients, for people who are the practitioners, the doctors, the nurses, even the techs in the hospitals that are run by these companies. So you have decades of deals being done in many different industries. And then in around 2005, you start to have a focus on healthcare. Part of the reason, of course, is that healthcare is an enormous part of the US GDP, 18% at the moment. That means that's a big money pot. And there are a lot of government programs that can be taken advantage of. So around 2005, I guess somewhere in that area, we start to see a focus on healthcare. And so we've seen $1 trillion go into the purchase of healthcare companies by private equity firms. They've taken over doctors' practices. They've taken over hospitals. They have staffing companies that oversee and manage emergency departments. In 40% of the nation's emergency departments are operated by private equity. So some of the details of just how in-depth this has gone. We have 8% of hospitals now owned by private equity firms. We have 9% of anesthesiologists. We have 11% of nursing homes, and that's probably low because they have very kind of secretive ownership structures. And then let's talk about the outcomes. Some very devastating studies recently. We had a study that said nursing homes owned by private equity firms, residents experience 10% greater mortality. 20,000 deaths attributed to this type of ownership. And this is an academic study that has never been refuted, never been questioned. We also have increased costs to patients. Anesthesia costs rose 26% after private equity took over. Oncologists, 16%. Ophthalmologists, 9%. Overall spending in hospitals by private insurance customers up 11%. So you can see the outcomes here. And over this long period, we now are very clear that this is a pernicious trend in an industry that people rely on. And the conflict is so basic. The conflict of interest between putting the patient first versus putting the profits first. It is only heightened by the private equity idea of flipping a company after 5 to 7 years. Don't forget, private equity was also absolutely at the creation of surprise medical billing. That's another gift the industry gave us. And Steward, the hospital system that was private equity owned, is in the middle of very messy bankruptcy proceedings, and they're in the headlines a lot. But the private equity firm that took them over made out like a bandit. So these are entities that put themselves ahead of everyone else. Patients first, practitioners, taxpayers, pensioners, everyone else comes secondary to their need for profits. How am I doing for time? I could go on and on.
Thank you so much. So we will have a, I'll ask a round of questions, and please everybody think about the questions you'd like to ask as well, because we will have time at the end. And I know that some of the panelists might have questions for each other as well. One thing that I know Harry would have wanted me to mention, apologies, is that please help yourself to tea and coffee during the session in the restrooms. Everybody has seen are in the back corner. Okay, thank you. Thank you so much, Gretchen, for that. So Anna, now turning to you, your report, Sick Development, was pretty explosive about the role of development finance institutions, including the World Bank's private sector arm, IFC, in global healthcare. Now Oxfam, along with 70 other civil society organizations, at least 70 others, is calling for a stop to this type of funding. So can you please tell us, for those who don't know about it, a little bit more about your research and how you reached this conclusion?
Thank you, Maaza. Can you hear me well? Great, thank you. So I wanted to start today just by sharing the stories of two women in two different countries. The first is Francisca. She's a young woman from Kenya. Her mother died of meningitis in Nairobi Women's Hospital. The family could not afford the bill, so the hospital refused to release her mother's body. They locked it in the hospital morgue for more than 2 years. The bill escalated every day. The second woman is Eva. She was advised to take her mother for emergency care to care hospitals in India. There, her government health insurance card, which entitled her to free healthcare and for her mother, was refused, rejected unjustifiably. The doctor there tricked Eva into buying private health insurance, but none of that insurance covered any of her bill. Eva said that she felt threatened by the doctor and that if she didn't follow what he said to do and what to pay for, then her mother would die. The hospital bill cost the equivalent of 7 years of Eva and her father's entire income. They sold everything they had and took out enormous debts. Eva said that every aspect of her life had been destroyed by this event. Connecting these two women and many others that we have interviewed is that the hospitals that they sought treatment and care from are funded by the World Bank's IFC alongside the development finance institutions of a number of European governments. The funds being used are supposed to fight poverty and achieve the Sustainable Development Goals. And the IFC claims that these investments in private hospitals will reach lower income patients and advance universal health coverage. Oxfam's research finds the very opposite. And Oxfam very much identifies the World Bank Group and particularly the IFC as a driving force behind an increasingly dominant narrative that encouraging and financing a greater role for the private sector and crowding in private finance is essential to achieve universal health coverage. It's a narrative that we think serves well the interests of wealthy investors and corporations looking to expand and make their fortunes in lower income countries. But it is a theory that is countered by the evidence, and when put into practice, brings with it significant and very serious risks of harm, both to patients and to health systems, as Gretchen has talked about. That the IFC has been almost universally silent on these risks, we think is irresponsible. My objective today is not to revisit the ideological debate between public versus private in healthcare. It's rather to examine the performance of the IFC itself as an institution and to assert with extensive and wide-ranging evidence of this performance that healthcare provision is not a place where the IFC should be doing business. Our latest investigations have been painstaking. Tracking the money trail between the IFC and other development banks to private hospitals in the Global South is a very difficult task, unacceptably challenging due to transparency problems. The research, as you probably can tell from my voice, has been the most harrowing I've ever been involved in. So what did we find? In the hospitals being funded by the IFC and the other DFIs, we found many cases of alleged and confirmed human rights abuses. This included patients imprisoned in private hospitals until bills were paid. We've identified cases of newborn babies locked in hospitals their mothers having to come and breastfeed daily because they couldn't afford the bill to release their child. In one hospital, we found over 30 cases that were widely reported in the Kenyan media over many years, including court cases in which the hospitals were found guilty and in violation of the country's constitution. But the IFC didn't appear to know about these cases. How is that? Not only that, but soon after we published our report, the IFC quietly exited its investment from that hospital. To the best of our knowledge, there has been no action to provide remedy to those many victims. We also found many patients like Eva, interviewed by Oxfam in India, who were unjustifiably blocked from using their government health insurance cards in IFC-funded hospitals. Instead of receiving free care, they were pushed into poverty with fees that they should never have been charged. This problem is not only in IFC-funded private hospitals, it's a problem that is rife across the country. Despite claims by the IFC that these government health insurance cards are the answer for access for low-income patients. We also found cases of emergency medical care being denied at the doors of IFC-funded hospitals. This included the cases of unconscious women and children involved in traffic accidents who were taken to these hospitals, but they were refused entry because they were too poor to pay. This isn't just morally wrong, this is illegal. And during COVID, at the height of the pandemic, when the capacity of these private hospitals was most desperately needed, we found evidence that IFC-funded hospitals were either closing their doors to patients or charging exorbitant fees running into the thousands of dollars per day for ICU beds in some of the poorest countries badly hit by the pandemic, including Uganda. In one case in Mozambique, Maputo Private Hospital charged $10,000 to get through the front door of the hospital if you had COVID. And this was a hospital that received emergency funding from IFC during the COVID pandemic. Beyond the problems of patient exploitation and abuse that we have identified, Oxfam collected systematic evidence of the affordability of these healthcare facilities. We focused on maternal health, which is a massive priority for Oxfam, and we know it's a big priority for the World Bank. But the fees charged in IFC-funded hospitals for maternal health care for childbirth are extraordinarily high. These are some of the most expensive hospitals in the countries that they operate. We found the average cost, the average starting cost of giving birth in one of these hospitals would take someone in the poorest 40% a year's income to pay, and that was just the starting cost. We know that IFC-funded hospitals in India are concentrated in high population cities where there is already significant healthcare facilities, and there is no facilities in where the access gaps are greatest. It's very hard for us to understand and rationalize what additional contribution IFC is making by funding expensive, large, and usually already very dominant players in the healthcare market in these countries, usually owned by extremely wealthy millionaires and billionaires. How can these investments be justified? And why is IFC funding mergers and acquisitions to help these powerful corporations become ever more dominant? Oxfam's research has found that the model of funding health pursued by the IFC and the other development banks is dangerously devoid of transparency and accountability, as well as good governance or any democratic oversight. Patients, communities, even legislators that Oxfam talked to had absolutely no idea that the IFC was invested in these hospitals. These problems are even more acute for the huge number of investments the IFC makes indirectly via financial intermediaries, primarily private equity funds. The IFC and other DFI staff have told us themselves that they do not have direct involvement in these indirect investments. And given the huge sensitivities of this sector and the real risk of and evidenced harm, this lack of oversight is completely inappropriate. The global evidence is also very clear that private equity has been bad for health. Gretchen has shared the shocking evidence from the US. Academic evidence from across many high-income countries concurs that private equity has driven up patient costs, has driven down patient outcomes, and has worsened labor rights in these, or labor conditions in these healthcare facilities and nursing care. So why on earth is IFC lending in this way? Why is it exporting the same approach that we have massive evidence is causing harm in high-income countries? Why is this model being exported to some of the most under-resourced and under-regulated healthcare systems in the world? What is also very concerning is that due to lack of transparency, we still don't have a full picture of the number and scale of these indirect investments. And we have made a number of requests to IFC to disclose these in full, but we're still waiting for a response on that. Where this information is available for other development banks, we have found that a shocking 80% of their healthcare investments are made via financial intermediaries, primarily private equity firms, and 80% of these firms are based in tax havens. So finally, the IFC provides no or minimal evidence of impact to counter the findings that we have published, and nothing to back up their claims that they are advancing universal health coverage. The lack of measurable objectives and the lack of any credible impact evidence is quite astounding, especially given the hundreds of millions of dollars being invested. For example, the IFC has been investing in private healthcare and helping to crowd in private finance in India for over 25 years, but we couldn't find one published impact evaluation. Based on the evidence that we have collected and the evidence that is available from others, we have no hesitation in concluding that the IFC's model of investing in private healthcare is dangerously unsafe. It's helping to further commercialize and financialize healthcare systems in lower income countries. It's exacerbating inequality, and it's without adequate safeguards to protect the rights of patients. All of this in already dangerously under-regulated contexts, facing and with people facing enormous unmet healthcare needs. We think it's an approach that flies in the face of evidence, and it's leading to exclusion, extortion, exploitation, and human rights violations. And that's why we have come together with 70 other organizations to call for this funding to stop now, and for an urgent independent investigation into the IFC's healthcare portfolio. Thank you.
Thank you, Anna. So turning to the IFC now, and we're really happy to have you here, Raju. It's important to have you as part of this discussion. Okay. Anna has painted a fairly alarming picture of your healthcare portfolio as IFC, both in terms of exacerbating healthcare inequality and poverty, but also how it impacts human rights violations. Anna has also highlighted your heavy use of private equity funds to invest in health, a model which Gretchen has said and has long researched, about the fact that it's wrecking healthcare in the US, and that it's taxpayers, patients, and health workers who are really paying the price for this. So I wonder if you could share with us, Raju, what the IFC hopes to achieve with its healthcare investments, and also what evidence you do have of positive impact, in response to Oxfam's reports and also Gretchen's evidence of the negative impacts of private equity involvement, specifically in healthcare.
Thank you very much. Let me try and put this into the context first before we get into the details. I think if you look across the globe, we all agree that there is a huge supply-demand gap between healthcare needs, what is available and what is needed. So that gap exists. Universal health coverage is the big objective, and World Bank's recently published objective of reaching 1.5 billion people with essential care by 2030. So all these objectives still remain strong. But now the question is, when you look at this supply-demand gap, how do you address that? Who should do what? So it is not about public versus private, or public should be the only one looking after healthcare, private shouldn't be there. So I think when we look at it that way, and me as an operator throughout my life, so when I put patients first, of course. So when I look at the supply-demand gap and who needs to do what, and healthcare, it looks very simple in terms of the needs. A patient gets sick, he or she goes to a hospital, see a doctor, get treated, get diagnosed, pay the bill and go home. It's a very simple need. But the complexities behind that is huge. You need to have proper infrastructure to begin with. Infrastructure, I mean, not just the buildings, the technology, the people, the skill set, good quality provision of care. Everything needs to come in place. And of course, financing. Everything needs to come into place to deliver that bigger goal of universal health coverage and everything. But if you look across the globe, the gap is huge. You might, even if you have a coverage today in some of the countries, you may not have the right level of care available at the right time, at the right place. So healthcare is not about hospital care alone. It is an ecosystem. So in a country where you have universal health coverage, or you have some sort of financing, but then you do not have a primary healthcare place to go to, you don't have an early diagnostics place to go to, you only have an hospital to go to, that's going to overburden the hospital system. So before we talk about universal health coverage, we need to put that infrastructure and the ecosystem in place. And that's where all these actors needs to come together. The public, the private, the healthcare funding people, health insurance, donor organizations, everyone needs to come together to do what they need to do to put this ecosystem together. And each person has got a role to play in that. And one person cannot do it alone. Like government cannot provide healthcare for the entire country all by themselves. Nor I'm not advocating that it should be only done by private. Wherever the skill set is needed, whoever can provide the best-in-class service, let them do that. But how do you make sure that this doesn't get out of hand, as many of the examples which you have looked at here? And that's where the regulatory framework and the checks and balances comes in. It doesn't matter who is funding. Without that proper regulatory framework and the guidelines and the structure in place, things will get out of hand. And that's what we are trying to mitigate in all our investment when we do. So when IFC, just to give you a quick context of when we look at investments, it's not about just putting money and investing, right? Even before the investment, as part of our due diligence process, we look at what is lacking with that potential or the investee company in terms of what do they have? Do they have the right infrastructure? Do they have the right management bandwidth? Do they have skilled personnel? Do they have the right technology in place? What are their practices in terms of clinical care and patient care and staff care, life and fire safety, quality standards? All these due diligence is done. And then when the gaps get picked up, we do provide a lot of knowledge investment as well to make sure that these gaps are mitigated. Advisory services to make sure that the company or that facility is able to mitigate these gaps and provide better healthcare to the patients. And during the life of investment and post-investment, the portfolio management continues, and we strengthen that portfolio management today to make sure that we hear about these things before it becomes a problem. When we hear about some lapses that, because I can tell you from my personal experience of 34 years living and working in hospitals, things will go wrong even if you have everything in place, right? Because it's a very human intensive kind of a service. You can have the protocols, you can have a beautiful building, you can have the technology, policies and procedures written in binders and kept there, but then the caregiver, the care receiver, all are humans. And every patient is different. Even if you provide the same care today, no, an incident-free hospital doesn't mean tomorrow it will be incident-free. Things will go wrong. Things can go wrong. So what happens if it goes wrong? We want to hear about that first. We want to make sure that these are not systemic failures. It could be an isolated incident. How do we address that? What is the corrective action, preventive action these hospitals and organizations can put in place? If they don't have it, how can we help them to mitigate and educate them to do that? So that's a huge amount of work which we do as a developmental. So it's not about financing alone. It is that value add which we bring onto the table and to the investment. And that's a huge thing which we do. And I think that's where the value add really comes in. It's not just the, and that knowledge investment is what the clients really look to somebody like IFC for, because with our global experience in looking at, as I was mentioning to you before the thing, there are no new mistakes. Sometimes this mistake would have done by somebody else in some other part of the world. We can learn from there, bring that knowledge across and cross, populate that and educate people. And so I think that value add is what is really important here, and the checks and balance, as I mentioned. So everyone needs to come together with the right regulatory framework, right checks and balances. Things should fall in place. Thank you.
Thank you very much, Raju. And just if I could, because you were very good on time, so I'll give you a brief, follow-up question. It's about the lack of evidence, that Anna highlighted here, that many of your own reports at IFC, highlight how these investments are crucial to achieving this universal healthcare. Is there evidence that you can point us to that this is working, evidence to counter these really stark findings from Oxfam and others?
So we do have an impact monitoring and measurement framework that is published on our IFC website now, but that is going through an iteration. Now there's going to be a next version coming up there. So the impact reports should be coming up, so depending on the type of investment and the type of facility, the indicators which we measure could be different. We might have a master list of indicators, but depending on whether it's a hospital versus a clinic versus a diagnostic lab or the indicators which we measure, but then it does capture the impact and to see how the investment is really benefiting and what it is, whether it is doing what it's supposed to do. So I think that framework is very much in place, and we do monitor that as part of our portfolio management as well. And it gets, of course, it's a work in progress, and because we need to also make sure that the hospital is able to, or the healthcare facility is able to monitor and measure these indicators. It's also like quality. It's not just about quality indicators, quality, clinical, service, operational, and financial indicators. And just to add one point, one of the value add which we just started doing a couple of years back is actually a benchmarking initiative. That means we collect these indicators, which I mentioned in these different buckets, from organizations across the globe, not just IFC investee companies. Any healthcare organization can be part of this initiative. They share their indicators. We anonymize and standardize those indicators and come up with a report as to how are they doing compared to their peers in that region or across the globe. And that report goes back to the client to see, how can I do better? Why is my infection rate worse than somebody else? What can I learn from that? So that's a huge value. And the response which we have gotten from the clients is very, very encouraging, because this is the data that is not available. But even if you compare blindly with your competitions, some of the providers, you don't know what is driving those numbers. So whereas we can actually standardize and give them insights onto that. So this is, again, a clear evidence of the impact which we are creating, other than just the financial investment part. Thank you.
Okay, thank you. I suspect we'll have some follow-up questions for you from our colleagues in countries that are receiving this IFC funding and support. So Abhay, I'm now coming to you, we know from Kate and also from Anna that India is the country with the highest concentration of investments in healthcare made by DFIs. We also know that IFC has been investing in some of the biggest corporate hospitals in India for about 25 years or so, yeah. So as a doctor and in your work with the People's Health Movement, you have dedicated much of your career to improving accountability, both in the public and the private sector, I believe, of healthcare in India. So can you share with us what you see as the impact of these investments for the Indian health sector, for universal health coverage and for patient rights?
Yeah, thanks a lot. So this is a great opportunity. Thanks to Oxfam for organizing this panel. And thanks to all of you for being here, and also my previous speakers who all, give some very useful insights. So I will be a little blunt in what I'm going to say now. But what I'm saying is absolutely the truth, and it can be verified. So first of all, I'll start with another story. This is from India, from Delhi, which is the capital. There's a huge, corporate hospital there, which is a major IFC grantee. Recently, it came on the headlines in the national newspapers for a kidney sale racket. And this was going on for several years. And these kidneys are basically, it's a transnational trafficking racket. It's not a simple thing. So poor people from Myanmar, which borders on India, are basically, their kidneys are purchased and they are brought to India, they're brought to Delhi, their kidneys are removed, and then the cost of buying a kidney in this hospital, this IFC grantee hospital, is over $100,000, which is like about 8 to 9 million rupees, which you can imagine is not a small sum of money. And this money, there's a gravy trail all along the line. So recently, two major officials of this hospital, which is Apollo Hospital, were actually brought under the scanner. This is not the first time this is happening. In 2016, 5 staff of Apollo Hospital were arrested for a similar kidney sale racket. Now, what is Apollo? Apollo is not an ordinary hospital. Apollo is the poster boy of IFC's investments in India's healthcare sector. Out of the $523 million, which has been invested directly by IFC, indirect investments are separate, $200 million have gone just to Apollo in 6 different projects. And this is the hospital which has repeatedly been violating its public obligations. It has been given almost free land in the national capital, which is a huge amount of subsidy, and they were supposed to give free care to poor patients. And the High Court of Delhi came down very strongly on Apollo because it was found to be repeatedly violating its obligations. So now this, I don't want to just tell you stories. I mean, these are real incidents. But the point is that what is IFC promoting in the private healthcare sector in India? What kind of model is coming in? You can get a little idea about it from these examples from Apollo. So basically, IFC is not just investing in a few hospitals. IFC is introducing and promoting a model. And we have to look at that model very carefully. In healthcare, there's something called market failure, which is known across the world. And you cannot treat healthcare like just another industry. So if you say we are doing business as usual, we are giving funds to various other businesses, and we're also investing in private hospitals without recognition of the potential of market failure, is a huge problem. And what kind of hospitals are being supported by IFC by and large? Now, let me share with you something which you might know. India has the 3rd largest number of dollar billionaires in the world after US and China. All of you know India is a very poor country, which is true. But fortunately or unfortunately, you also have a huge number of billionaires. Now, the interesting part is, out of these $200 billionaires, the 2nd largest chunk is from the healthcare sector. And these dollar billionaires, they're huge. Apollo, Max, Fortis, these are the ones which are being funded by IFC. So it's these dollar billionaires and millionaires which are already super rich, which already have enough funds, in my understanding. So you are the tip of the top of the pyramid if they are further being funded to do, certain kinds of things, how is this improving poor people's access to healthcare in rural areas or in the urban poor or the tribal people of my country? I don't understand. So the point is that this model is affecting the entire ecosystem. And I agree with Raju, it's an ecosystem. But the part of the ecosystem which maybe we lost sight of is that the public health system is a system. The private healthcare sector is not a system. It's just a collection of providers who are each of them are just fulfilling basically their own interests. So, in this kind of situation, we have had multiple examples. I'll just give you a few more examples. During the COVID pandemic in Maharashtra, the state where I'm based, which had the maximum number of COVID deaths in the country, and by accurate figures, India had the maximum number of COVID deaths in the world, according to WHO. We documented dozens and dozens of cases of violations of patients' rights in private hospitals, which also included IFC investee hospitals. So one particular hospital in Maharashtra, it's a hospital chain, we documented 6 cases of gross overcharging, which were substantiated by the government of Maharashtra because it is a public hospital, public audit. And in 2 of these cases, more than 1 million rupees were charged from COVID patients. And many of these unfortunately died also. So, and this was in gross violation. So of the, regulations of rates, something like 450 to 500% higher rates were charged from COVID patients. So now this does not fit in any logic of access or equity or universal health coverage or any such thing. Another important aspect which I'd like to emphasize, and maybe Mercy will also add in this, is the point that this model of corporatization, financialization, hyper-commercialization, and privatization of healthcare is leading to clinical targets being given to doctors in hospitals. You must be wondering, what is this clinical target? Now, my colleague Arun Gadre and myself have written a book which has been published by Penguin. It's called Dissenting Diagnosis. It's a kind of a bestseller. In this, so Gretchen, so in this book, we have interviewed 78 whistleblower private doctors across India. And they have told us what is going on in some of these corporate hospitals. They may be IFC supported or not, but basically that kind of group of hospitals. Now, clinical targets are that cardiologists have told us that they are given clear targets that out of every 100 patients you see, 40% must undergo an angiography or an angioplasty, whether they need it or not, because we have taken a huge loan. It may be from IFC, it may be from somewhere else, private equity. And as you said, as Gretchen said, there's a very short time frame. We have to repay this loan in the next 5 years. So every patient who enters into so the indication for an operation is not whether the patient needs it or not. The indication is that we have to repay the loan. So hundreds and thousands of unnecessary cesarean sections, these have been documented, unnecessary hysterectomy operations, unnecessary procedures of various kinds, because targets are given by the hospital management, which is flowing from a different logic of financial maximization of financial returns. And these hospitals maximize their profits essentially through 2 channels. One is overcharging patients, and the other is underpaying staff. So I think, Mercy will be talking about that. So in this kind of situation, I'll just say that, 4 or 5 things which maybe Raju may like to respond to. IFC has basically not contributed in a significant way to expanding access to healthcare for the poor in India. It has driven up costs of healthcare dramatically in large cities because of its mode of operation. It has contributed to violations of patients' rights, like detention of dead bodies of patients, the kidney racket and other things. It has also driven privatization of public health services. And the 5 major investments of IFC in Maharashtra, the state where I'm based, are all for privatization of existing public health services. 3 involve handing over of public hospitals to private players for long periods of time, and 2 involve major outsourcing of lab services and radiological services to private providers. So just to conclude, the point is that these projects are all IFC's projects, as far as we can see, are promoting a private first kind of model in a situation which already there is a lot of privatization. India is one of the most privatized healthcare systems in the world. It's driving further privatization, market failure instead of being corrected. is actually being exacerbated, and regulation is completely lacking in the picture. In the last 25 years, IFC has provided multiple advisory projects to India. In my understanding, not even one has led to regulation of private healthcare in India. And it's a huge problem which we need to address. So I completely agree with Anna that this kind of investment needs to stop until there's some fundamental reconfiguration of the way in which this is being provided.
Thank you very much, Abhay. One thing before I go to Mercy, one point that I want to highlight in terms of the DFI's claims, including IFC, is that one of the major benefits of their healthcare investments is that they create more jobs, especially for women. So with that in mind, I want to turn to Mercy to speak to the situation in Kenya. As with India, my understanding, Mercy, is that Kenya is home to a very high number of these private hospital investments, including by the IFC. So from your perspective, advocating for health workers and the health force, do you think these investments are actually making a positive contribution in terms of jobs and, of course, into women's economic empowerment that everybody likes to say they're contributing to?
Thank you, Maaza. Just to share some statistics about IFC's involvement in Kenya's health sector, and especially the private health sector. So Nairobi is Kenya's capital city. That is where we have the largest concentration of private providers. And IFC's involvement through just one US-based private equity fund is responsible for 66% of healthcare provisioning in Nairobi's private health sector. That is huge, given that close to 3/3 of Nairobi's population live in, urban informal settlements. And so you can imagine the kind of things I'm going to talk about and how this is really having a negative impact in the lives of healthcare workers who work in these facilities. But I just want to start by posing this question to IFC, to my brother Raju here. How do we place these jobs that IFC is claiming to be creating through these investments? Like, how do we place them within the UN and the ILO decent work agenda for sustainable development? Because it's all about development. It's all about universal healthcare coverage. But are these jobs decent? And ILO has come out clearly, and the UN has defined what decent jobs are. These are jobs that, enhance the rights at work. They are jobs that enhance social protection and social dialogue. And they are considered to, improve dignity, address social justice, and address, improve equality. But this is far from what we are experiencing as healthcare workers in these facilities. These jobs are not decent. These jobs are not dignifying. These jobs are dangerous. And why am I saying that? Abhay talked about, clinical targets. In these hospitals, and this is public, close to 5 years ago, the staff, many of them in these hospitals came out on social media, shared messages from their CEO who was telling them about their targets. It was publicized. It's still present, on social media platforms where the CEO was telling them, tomorrow, our targets are to make sure that all our beds are filled up. Tomorrow, we must make sure that, the new reagents we bought in the lab, we get them used up. So make sure you do your work, meet those targets, do all these things. This came out publicly. It's part of the report that Anna has talked about. But I'm sorry, Raju, that IFC has not done anything about these reports. This same hospital has been litigated against, abuse of patients' rights, abuse of workers' rights. What did IFC do? IFC slowly exited their investments in this hospital, but no remedy to the patients, no remedy to the workers. But let me just talk about the indecent jobs, or the kind of work jobs that we are seeing at these facilities. Healthcare, you know, the work of nurses, the work of doctors has been traditionally considered very respectable jobs, very decent jobs, very secure jobs. But this is no longer the case. Kenya has had one of the, you know, and has had unprecedented healthcare unrest. We have just come out of a 56 days doctor strike. We have clinical officers who are now going to almost 100 days of strikes because of deteriorating labor, you know, standards in the country. And these are things that are being driven by this kind of models that we are now seeing in our countries, where doctors are employed on casual terms. These hospitals will only employ 2 or 3 resident physicians. Then the rest of the physicians are employed on casual terms. So as a doctor, you come to work today, you do your 10, 12 hours, you meet your target, and you get paid. If you show up tomorrow, well, you'll get paid. If you don't show up, that's it, you know? And this is something that has made, you know, even the practice of medicine to become indignified right now in the country, to become indecent for the healthcare providers. It's dehumanizing to make a doctor who trained to provide care to begin looking at the patients as commodities, to begin having targets that from this patient's illness, I have got to make money so that we are able to repay some of these loans. And so what's happening to our healthcare workers, what we have seen documented here in the US, has started being the story of the healthcare workers in Kenya. The US has the highest rates of suicides amongst physicians. And this is what we are also now seeing in Kenya. Just 2 weeks ago, we lost 2 clinical officers. One of them was working at Avenue Healthcare, which is one of the IFC-funded healthcare facilities. And they left a suicide note where they clearly indicated that it's the pressures of life, the low wages, all these things, they are unable to sustain their living, you know? So we are not seeing these claims that IFC is making about creating jobs to be real. They are creating jobs, but these jobs are indecent, indignifying. You know, they do not meet the standards of what we call quality jobs. But when I talk about, you know, whether they empower women or whether they address gender equality, I mean, how can you claim to be addressing equality or inequality by establishing certain forms of inequality or perpetuating existing inequalities? These jobs in the health sector that are being created, that are indecent, that are paying very low wages, we know that care jobs are usually taken up by women. This kind of precarious jobs, it's mostly women who take them up. And so what is that doing to them? What is that doing to their conditions of life? What's that doing to their families? What's that doing to their communities? These kind of things are things that even as you talk about your due diligence, is it real? Is it true that this is taking place? I know that one of the performance standards for your investments talk a lot about labor standards, but I want to say it clearly that if you claim to do any kind of due diligence, then you haven't done that in these investments. Why? Because it's documented. It's public knowledge what's going on in these hospitals. It's not a secret. We know that they have claimed in their websites, we have 1,800 employees, but only less than 10% of those employees are employed on long-term contracts. The rest of them are casual workers. The rest of them are paid very extremely low wages. In fact, these hospitals, despite charging very exorbitant fees, pay way lower salaries than what healthcare workers in the public sector. And now we see, I mean, one of the reasons why we have so many strikes, it's because every healthcare worker in Kenya does not want to work in the private sector. The conditions are horrible. To quote our doctors, they say, who work in the private sector, they say our sector is brutal. This sector is brutal. We live one day at a time. We survive. And if you do not have a thick skin, you will not survive this sector. That's what our healthcare workers are saying. These are providers. These are carers. They're supposed to take care of sick people, and now they are sick as a result of this kind of models that we are seeing. And so as a union that represents healthcare workers, not just in Kenya, but also in East Africa, we've had a problem, and we continue to have a problem, especially on the fact that this information, who is behind this kind of investments, has been hidden from us, has been hidden from the practitioners. Until the Oxfam report came out, even the doctors who work in these facilities have had no idea that IFC was involved, had no idea that even American private equity funds were involved in, in these businesses. And so we are calling for more transparency, more accountability, but most importantly, ILO, the UN has set out strategies for promoting decent work. And these include investing in education and training, promoting fair wages and working conditions, and promoting gender equality. None of these investments are doing that. And so there's no need of continuing with this kind of model, especially in a country where 80% of the population lives below $1 a day. Why are we making them more poor? So I joined Oxfam. We are part of the CSOs that are calling, for a stop, for IFC to stop these investments. Thank you.
Thank you, Mercy. And Gretchen, especially following Mercy, I'm eager to come back to you now that you've heard Mercy, you've heard, the fellow panelists. And I'm curious to know if you were aware that this trend of private equity ownership of healthcare that you've so sort of devastatingly critiqued in your book and in much of your work, did you know that it was being replicated in the Global South, financed by these publicly owned development banks? And I'm just curious to hear what your reaction is to that, and what warning you would have for the rest of the world from the US experience.
Well, I'm not surprised. I was surprised about the depth, the scope, I guess, of these investments in these countries. I'm not surprised about the US. The US is well known. They did it in the mortgage crisis for exporting their problems, their financial problems, their financial instruments of disaster. So we're very noted for exporting that kind of stuff. Not surprised about that. But some of these comments, talking about what's going on in India, talking what's going on in Kenya, these are all the kinds of things that I hear about constantly from people that I talk to in private equity-backed institutions, hospitals, doctors' offices, practices in this country. So it is all very familiar to me. Mercy was talking about looking at patients as commodities. Well, one of the companies that I've covered has a name for patients. They're called revenue units. And when I heard revenue unit for a human being, it just made my skin crawl. But that is exactly what we're talking about here. Everything goes down to the bottom line. So, should this be a focus? Absolutely, this should be a focus of what is the purpose of these, this infiltration, this financialization of healthcare. What does it achieve? We have enough data. We can see what it does to patients. We can see what it does to pensioners, to workers, to taxpayers. And when these companies go bankrupt, which they are starting to do in this country because of high interest rates, you're starting to see the model really start to crack open. And so when you start to see hospitals going bankrupt because their private equity owners stripped them of their assets, took the real estate underneath the hospitals and sold them for their own gain, then you start to see the kinds of pernicious and, the impact that this industry and these financialization practices have on human beings. So I am surprised at the scope and the depth, but it is all very, very depressingly familiar to what we have encountered in the past 20 years in this country, 15 years in this country.
Thank you, Gretchen. And Raju, I am going to follow up with you in a second, but before we come back to you, I want to give Mercy an opportunity. Mercy, do you have, just to follow up on your points earlier, do you have any clear asks? So, what do you think needs to happen in Kenya to address some of these issues that you laid out? And, after you, I want to go back to Raju and give him a chance to respond to some of these things with a follow-up question. But yes, you've talked about these unstable contracts and so many of the issues that you laid out. What would your demands be to the IFC and other financiers investing in private healthcare in Kenya? But please try and keep it brief so we can also have the audience chime in with some questions.
Yeah. So so first and foremost, because IFC has made clear claims that they do due diligence, that they create jobs, that they do all. We would like to have that impact report made public, shared with us. Would like to know some of these matrices, and we also would like to know where there has been gross violation of workers' rights, what remedy has been provided, or what remedy is going to be provided. And this is where IFC has had its investment, irrespective of whether they still are investing there right now or not. But most importantly, we want to see clearly, are you investing in strengthening the health system and creating decent jobs? Can you guarantee that within the existing tenets? Because if you cannot guarantee that, then you need to stop these investments. Thank you.
Thank you, Mercy. So Raju, you've been listening patiently. Thank you for that. And so I just wanted to drill down a little bit now and ask more about the specifics of how IFC is responding or would respond to, the demands from people like Mercy. Abhay, we're going to come back to you in a second, but also, Oxfam's report. And in addition to Oxfam, my understanding is that the UN Special Rapporteur on the Right to Health, the UN independent expert on foreign debt financing and human rights, also wrote letters to the World Bank group expressing their concerns. So, I guess to kind of try and put it simply, like, what has changed, what will change when it comes to IFC's role in healthcare, and what commitment can you make today, if any, to Mercy and her demands? And I'm sure Abhay, as I said, will have a few more concerns to express as well. Thank you.
Thank you. I guess the fact that I'm here today is also evidence that we do value this feedback. We want to hear what is happening on the ground and how can we strengthen some of the things which we are doing today with the goal of good patient care. That is still the ultimate goal. But as I mentioned earlier, even with all these checks and balances, there are lapses, there will be lapses. So how can we mitigate that? How can we learn from that? And how can we strengthen from that? So even back to Mercy's point on the working conditions of the staff and job creation, yes, there is a strong ENS, environmental and safety due diligence. So I can take this back to the team and get them to respond to that. That is not an issue. And in terms of what has changed, as I mentioned, we have really strengthening that portfolio management to making it mandatory for the companies to report some of these indicators, seriously reportable events, not just patients, even affecting the staff. If there is reportable events that needs to report to IFC, or all the shareholders or investment firms that has invested in the company, to make sure how can we help them to change some of these practices if there are systemic failures, or if there's individual failures. We want to know what corrective action they have taken. Most importantly, what preventive action they are taking to make sure that these things don't happen again. So that framework is being strengthened as I speak. So I think that is a very clear on the ground action that we are listening, and we want to welcome the feedback from not just Oxfam, but from many similar CSOs on the ground and other organizations. So I think that itself is a testimony. Just to add to that is, when we see some of these practices are not happening on the ground, that was in 2019, we started this initiative called Ethical Principles in Healthcare, or in short called EPIC, which is basically to bring together organizations to look at 10 basic principles of providing healthcare in an ethical fashion. It's not an audit or an assessment or accreditation per se, but it is a group of like-minded people to come together, learn from each other. How can they implement some of these principles in their facility to make sure that things fall in place? So as I said, there's no quick fix. It is a long-term, it has to be a long-term sustainable solution. We all needs to come together with the regulations and checks and balances in place, and willing minds, which we are ready to listen and take corrective action on the ground. I think that is a solution. Thank you.
Thank you, Raju. So Abhay, I'm going to come back to you now, and just so you can bring us back to some of the realities in India. Do you think that the response from IFC to date is adequate? I think I can anticipate the answer that you'll provide, and if you could give us an idea briefly as well, please, so we have time for questions. What else needs to happen to ensure universal health coverage, equity, patient rights, that all of those are really advanced with the support of development funding?
In India, we have a saying that you can wake up somebody who is sleeping, but if somebody is pretending to be asleep, you can never wake him up. I think you understand what I'm trying to say. So my point is there an intent? Only if that intent is there, then change can happen. So my first point is, please don't export the flawed and failed model of US healthcare to our countries. We don't want it. Thanks, but no thanks. Okay. So we don't want this model. You should stop all further investments in private healthcare until a thorough, independent, multi-stakeholder review involving social stakeholders, civil society organizations, trade unions, women's groups who are centrally involved. Unless that kind of review has taken place, we don't want this failed and flawed model anymore. Number one. Number two, regulation has to be at the top of your agenda. What is the World Bank Group doing about regulation of private healthcare in countries like India? Zero. Okay, maybe it's not directly in IFC's mandate, but it's definitely under the World Bank's mandate. And I can tell you, India has one of the most unregulated private healthcare sectors. There's no regulation of costs, very little regulation of quality of care. There's a Clinical Establishment Act, which was passed in 2010. In 2024, it is yet to be implemented. And so many billions of dollars or hundreds of millions of dollars of funds, so much technical assistance. Where is regulation? Regulation is nowhere on the agenda. So you cannot invest in a situation which is completely unregulated. It's like there's an elephant, which is wild. Okay. Now this wild elephant, you go and start injecting it with anabolic steroids. That is what financing does in an unregulated healthcare system. So please don't inject the elephant with steroids. Instead of that, tame the elephant, or help to tame the elephant, or at least help our own countries to tame this elephant. We are saying, okay, the elephant is going to be around. It's not going to disappear. But if you inject it with steroids without taming it, it's going to create even more havoc. So regulation has to be at the top of the agenda, not somewhere just mentioned and nothing is done about it. Complete transparency about the entire set of operations. Today, these hospitals don't even display their rates. I mean, transparency, nobody, 99% of people don't even know that they're IFC grantees. We came to know after the Oxfam report that, all these hospitals are actually IFC. It's almost like a secret. So this is like completely unacceptable. It has to be completely transparent, whatever is going on. And basically, the entire scenario is such that it's a matter of deep concern that market failures are being, accelerated and exacerbated because of IFC investments. This model has to, at least there has to be a moratorium on these kind of investments until regulation, social accountability, workers' rights, patients' rights, and the larger health system impacts of these kind of investments are thoroughly reviewed, and in which all, including our own country governments, our civil society, and our trade unions, etc., are involved. That is absolutely essential. Otherwise, this model is completely inappropriate. And I think Mr. Raju and his team need to do some more thinking. If you are sleeping, you can be woken up. If you're pretending to be asleep, then something else has to be done.
Thank you, Abhay. Anna, I'd like to come to you next to ask, following our discussion today, are you closer to feeling like IFC is doing what it needs to do? And you've already mentioned what you would like to see, to Oxfam would like to see IFC do next, but I wanted to give you the final word on that before we hand over to questions. So please, everybody, if you could get your questions ready. So please go ahead, Anna.
Thank you. And, I have to say, we published our 2 reports a year ago. And we have had quite a lot of dialogue with IFC since then. And we're very appreciative of you coming here today, Raju, for sure. And we're very appreciative of the time that has been taken to talk with us. And we've had 5, 6 engagements since we published our report. So we're thankful for that. But I do have to say that I don't feel like we're progressing. And I feel like we're hearing the same responses. And we haven't moved forward, and we don't have answers to the questions that we have asked. So we have been told by the IFC team that they have looked into the cases that we've raised in our report. But when we've asked for details of what actions has been taken or what they found, they tell us they can't share that information due to non-disclosure agreements or commercial confidentiality, which is difficult to swallow. We heard again today, in response to our asks about what impact of evidence is available, that there is an impact measurement framework, but I think, we didn't hear that there is impact evidence available for public consumption. And as far as we understand, that still is the case. So again, we find that quite unacceptable, to be polite about it, given the astounding amount of money that the IFC has invested over the last 2 decades, that we don't just even have basic impact evidence in the public domain, that people, activists and communities, patients can see and can analyze. And what we are told, and what we've been told about the actions that are taken, seem to all rely on the IFC, on the companies voluntarily telling the IFC what they're doing and how awful things are in their companies, as if they are going to self-report that they're involved in kidney rackets or involved in patient rights abuse. So, something's not stacking up here in terms of the gravity of the actions being taken. And again, we're told that changes are being made to due diligence and supervision, but we're not given concrete information about what those changes look like, no consultation about whether those measures are appropriate or not. They've also told us that in order to better reach low-income populations, that they're now looking at expanding their portfolio into primary healthcare. And rather than this being a reassurance for us, we're actually very alarmed about that. what is the plan to disrupt and extract profit from primary healthcare? And how does this marry with the World Bank's own goal or own commitment and policy that primary healthcare should be free of charge? So that's a big question for us. And unfortunately, we know from IFC's investments in education, which suffered many similar scandals to those that we have found in health, that the IFC knew of many of these problems and they did fail to take proactive steps to stop them. The end result was extremely damaging for children, families, and teachers, and for the IFC's reputation. And it took external pressure outside of the IFC for these scandals to be investigated and to bring a stop to IFC investing in private schools. And we're now urging for the same kind of pressure now to stop these harmful investments in healthcare and to insist on this full and independent and multi-stakeholder inquiry before more harm is done. And that's why we're happy that so many organizations and experts, as this information becomes more known, as we raise awareness around the countries where these investments are taking place, they're joining us in calling for this investment to stop. But we need those with a stake in the bank to listen and to act. We need the leadership and the board members to step up and speak out. It's incredibly difficult for victims and survivors of malpractice by incredibly powerful corporate healthcare providers funded by the IFC to come forward and make complaints. We will always encourage and support that if they choose to do that, but we know that that is very difficult to do, and that's why we need proactive investigations to be instigated by the bank as well. But we also need a change in mindset and approach. We do need the World Bank leadership to recognize that there must be some no-go areas for their dominant private finance first approach, that the risks in some sectors of harm are just too high, and that some sectors, especially those responsible for delivering fundamental human rights, are just too precious to commercialize and financialize. That decision to stop those investments has already happened in education. The IFC no longer invests in private schools, and we now need the same decision to be reached for healthcare provision. Thank you.
Thank you so much, Anna. So now we have an opportunity for you all to ask questions, and I think Harry might be the one who's going to take a microphone around. So if you have questions for any of our, yes, there's already a hand up. Wonderful. Please introduce yourself. And if you have somebody you're directing a question to specifically, please say who that is. Not yet.
How about now? Wonderful. Thank you. Thank you all so much for this really rich discussion. My name is Dana Brown. I'm the Director of Health and Economy at the Democracy Collaborative here in DC. And my question is for Raju. Thank you so much for being here and being able to respond to these questions. I'm wondering if you can give us an example of a country that has achieved universal health coverage, a lower middle income country that's achieved universal health coverage by relying on private finance, because that's the rationale we're always given for the need for this influx of private finance in the sector in low and middle income countries. When I was in public health school studying health economics, that's what we were taught, that you're only going to get UHC through a mixed capital approach with private finance crowding in public, blah, blah, blah. But the evidence base we were offered is very thin, and I'm still not aware of any country that's achieved universal health coverage that way, while there are countries that have achieved it through public finance. So if you can give us an example, that would be very enlightening for me. And also if you can tell us how the health equity outcomes in a country that's achieved coverage through private finance stack up against those that have chosen a public financing route. Thank you. And sorry for putting so much out there, but this fascinates me.
Thank you. I don't think there is a country that achieved universal health coverage today. It is a work in progress. And as I said, it's not about just financing. It is also building that infrastructure to keep the universal health coverage sustainable in the long run. So I think it is a work in progress. So, but there are examples of countries moving, many countries moving in the right direction, in getting the funding, willing to put the infrastructure in place, willing to improve the quality of providers who are able to provide good care when the coverage becomes available. So there are many examples of such countries. Egypt is one example which I can quote, where it's very good collaborative approach with the Ministry of Health, Ministry of Finance, and also the accreditation body in terms of looking at improving the quality of care provided. So it is a combined work that is in progress. Thanks.
Thank you, Raju. And we have Abhay who wants to chip into your question here.
Yeah, I mean, your question was not to me, but I'd like to say that there's a counterfactual. And that counterfactual is that all systems of universal health coverage or care which have been achieved are through public finance. And we have to take that note of that. So if we are making an exception and saying that some countries can do it through private financing, there has to be a very good reason for that. Otherwise, the default option is public finance. So let's keep this in view. Whether it is Thailand or there are many other examples, there are Scandinavian countries, there are many other, both developed and also some developing countries, everywhere, single payer, publicly financed, primarily publicly financed healthcare is the way to go for universal healthcare. I think that is the global experience until now. And the fact that there is no country which has achieved it through private financing is itself a fact which we need to keep in mind. So the promise may be there, but the reality doesn't show that it's working until now.
Thank you, Abhay, and thank you, Raju. Any other? Yes, I see another hand. Yes, please introduce yourself and say if there's someone you want to ask the question to.
Yes, thank you. Hi, I'm Stephanie Amwaku. I'm with Accountability Council. Thank you for this great panel today. I guess to you, Raju, thank you so much for being here. And another question directed towards you. Getting back to Anne's, I guess, specific points on what IFC has, how IFC has responded to these cases. What is the responsibility of IFC to remedy these harms that different communities have experienced? And I ask this in the context of my organization. We support communities who have been affected by investments from IFCs and other development finance institutions, and the role that the development finance institutions play in crowding in finance, in giving a sense of legitimacy to different projects and different investments. And then also the standards that IFC itself has that they have agreements with the clients will be followed. But we've seen in different instances that IFC is not actually monitoring whether that's being followed. So I think today, like from you, we've heard some great, well, I'll let others assess how great they've been, but it's commitment towards future-looking actions, which we hope will address the harms going forward and prevent them, I should say. But what is IFC doing to address the past harms? Because there are people today who are suffering from those past harms. And so what are the concrete steps that IFC can take as a part of their responsibility and development mandate to address those harms?
I guess the short answer to that question is, as I said, we do take this very seriously. So for the past harms where we are still involved in the investment, where we still have a say in the investment, we will definitely looking at what the corrective action which the facility is taking, how to prevent that. How can we help, not just being a policing body, but to see how can we help them to strengthen some of the lapses in their system and provide that advisory as well. Because sometimes it's easy to pick the fault and say that, okay, this you didn't do well, but then sometimes it could be ignorance of how to do it better. And that's where we do provide that service as well to make sure that they are able to mitigate some of these from happening again and providing that advisory and that knowledge sharing. So that's something which we are already doing it. But as I said, going forward, definitely we hear this and take this feedback very seriously. And that's why the strengthening of the portfolio management, which I mentioned, that in a more structured, not that we are not doing it today, but in a more structured way, making it measurable and reportable and manageable. Thank you.
Anybody else? Yes, there's another hand. Wonderful. I love it when all women ask questions at panels. Yeah.
So I would really like to understand better.
You please introduce yourself.
I'm Eileen Applebaum at the Center for Economic and Policy Research.
Maybe you just put the microphone a little bit closer to your mouth.
Okay, is that better? Okay, great. So my difficulty in all of this is understanding a few things. First, what are the penalties if the hospitals don't go along? What happens to the private equity firm? Do you have a way of excluding it from future work with you, or do you close down its operation? What do you do about it? You know, we have penalties in this country, and the private equity firms here just look at them as the cost of doing business, because they're basically a slap on the wrist. They are making so much money, which you for sure have to know that they don't care. You want them to say, yes, they're going to do this or that. You want them to make a small change around the edges. They're happy to do it. They're raking in your money. They're raking in your money, and that's what counts to them. I wonder even how you reconcile in your own mind private equity, which has a laser focus on making profit for itself, does not even share it, making profit for itself and its investors in a very short period of time, as Gretchen pointed out. They won't be there for your long-run solutions. It'll be a whole other private equity company that's going to be there. That's what they do. They sell from one to another. And so what's the penalty to them? How do you reconcile in your mind this laser focus on short-term profit with the ideal of good health care for everybody, for poor people, but even for those who are not poor? We have that problem in this country. You don't have to be poor to be mistreated at a private equity hospital, private equity-owned hospital. So that's what I'm wondering about.
So when I say regulations and penalties, it's not, IFC is not in a position to penalize or put in the regulation in that country of operation. That has to be a combined work with the government or the regulatory bodies. But in terms of choosing the partners to work with, definitely that's something which is within our control. So if we see that, okay, we have a partner today who is not doing the right thing, who is not like-minded, is not aligned with our strategy and our thinking, we have the right not to work with them, and we would decide that way that, okay, this is not the right partner for us. Or even if it's an investee company, this is a company not for us, this is not the right partner or the right investment for us. And that decision stays with us. But penalizing a company for wrongdoing, that is within the jurisdiction of the local regulatory bodies.
But you could withdraw the finance, right?
Come again?
You could withdraw the finance. You don't have...
Whatever we can do from our end, finance, yes, that's fine. But what I'm saying that is penalizing or putting a fine or regulatory restrictions on them, that really depends on the local regulatory bodies.
It would be useful for us here in the US to know which are the private equity companies that you find do share your goals and values and value patient care above their personal profit.
I don't have that information with me now. I'm sorry.
Okay. Well,
okay. Yeah. Thank you. And I would like to encourage people who have questions for others aside from Raju to please chime in. But I wanted to take advantage of my kind of moderator's liberty here to ask Gretchen, if you were to be asked in the United States, what redress have you seen in these types of situations? Because I know that this is
very little redress. I mean, and Eileen knows this better than most, when a private equity, often the private equity company is long gone when the problems really, really emerge, like the Steward bankruptcy, which was a group of hospitals taken over by Cerberus, very aggressive private equity company. And they're now going bankrupt, but Cerberus is out. They're long gone. They made how much? 3 times their money? And so there is very little, it's very difficult to see how you're going to tag them with this. Now, bad headlines is one thing, but they don't really care about that. Now, one of the companies I think in India is Blackstone, right? Okay, so, here is a company that in the last year or so has been in the headlines for a portfolio company it owns that hired children to clean slaughterhouses across the country. So I guess my question is, to what level of kind of disastrous practices does it have to reach before people will make a change in dealing with those people. You know, for instance, CalPERS is an investor in the Blackstone fund that holds the portfolio company that was hiring 13-year-olds to clean slaughterhouses. I called CalPERS when these headlines first started to break, and I said, I'd like to know, are you rethinking investing with this company? Are you estimating whether you want to be involved with a company that has, as a practice, hiring 13-year-olds to clean slaughterhouses? CalPERS' response to me was no comment. And so you have to ask yourself, what level of degradation is required for people to say, enough, I'm not going to deal with that?
Thank you, Gretchen. And yes, as you know, as Gretchen mentioned, Blackstone is a hospital group that features in Oxfam's report and is implicated in the denial of emergency care and the impoverishment of patients who were reportedly denied care that should have been free to them. I know Mercy wants to chime in, and then I think after that we'll have time for we have one, so let Mercy chime in and then one other question.
Yeah, I just also want to give an example in Kenya. One of these private equity funds is TPG that had ownership in Nairobi Women's Hospital, Metropolitan, and London. When the Oxfam report came out, TPG had ownership of these hospitals. In the last 6 months, it has made every effort to sell off its shareholding of these companies, and it now no longer, owns these hospitals. But these things that we are talking about, these violations of workers' rights, the sexual harassment, who's going to take responsibility for that? Because TPG is out, IFC is out. They've sold them back to Kenyans, back to other, people who cannot be held responsible for these past atrocities. So as we keep on saying, this kind of model is wrong and it should not continue. Yeah.
Thank you, Mercy. And, I think there have been commitments to, possible next steps, but I think what this also shows, and I know that your civil society liaison is here, that, when all this redress is still hanging over people, traumatized people who have been left with undignified work, that the trust that IFC is trying to build with civil society and these countries will be sort of, damaged by that as well. So something important to keep in mind. Yes, Harry, do we have another question? Please say who you're asking it. Introduce yourself and address it to the person.
Hello, my name is Rachel Nadelman. I'm from the Accountability Research Center at American University. This question is for Anna and for anyone else. But so, you've talked about how the IFC has been willing to sit down and have conversations and hear the evidence. And perhaps the conversations go like this has today. There's a little bit of talking past each other. And so do you have strategies of what to do next? I mean, what Gretchen just talked about, the headlines don't change anything. And then you have no comments, or you have no countries have gotten there yet. And there's not the impact evaluation. So what do we do now? Do you have ideas? Because, sitting across face to face, which is a good first step, but it doesn't change anything.
I know Abhay has some ideas, so I will definitely let you speak to that too. Well, I mean, I suppose, we will continue making our demands. We will continue putting pressure. We hope that as we raise awareness, and we've already seen this in many countries, in Kenya and in India, that this will prompt more investigations, more evidence coming to light. We hope that complaints will be made, but I have said, as I've said already, that I think that is incredibly difficult for communities and survivors and victims to come forward. So we really do, we will keep pressing for this independent evaluation. We know that there is precedent for the ombudsman of the bank to self-initiate investigations, even when complaints haven't been made, when there is sufficient evidence to warrant that. And we would welcome that kind of thing being considered, and would welcome board members giving consideration to that as well. But I think, you know, I don't think things are going to change unless there is people power. And for that to happen, we need to organize. The work that the unions are doing with under Mercy's guidance is so incredibly important to bring people together to demand change on this type of thing. So I think that communities, activists working together in dialogue, ideally with the IFC and with the World Bank Group. But as I said before, I don't necessarily think that the IFC has demonstrated over the last year that it is taking our findings as seriously as it must do. And for that reason, I do think we need to step up the external pressure through stakeholders of the bank, through governments who have a big stake in the bank, to enforce that that action is taken. But I know that Abhay might have a different perspective.
It's not different, but yeah, thanks, Rachel, for the point. So in India, we are fond of drinking tea. So like you can put water and milk and sugar and the tea powder, all of it together, you won't get tea until you have the fire. We have to raise the temperature. If you want tea, we have to raise the temperature and it has to boil. So the point is people, civil society, social organizations, trade unions have to start making this into an issue. At least we start raising the questions. What are these corporations doing in our country? And those who are funding them, what are their strategies? Where is the information? Where is the evidence of impact? And we have to also work with our own country governments. So, you know, it has to be made into a social issue. The future of healthcare in every country of the world is either towards financialization or towards socialization. And this is a choice which every country needs to make. The more and more we go on the path of financialization, all the things that we have been talking about will, you know, further disasters will happen. These are inevitable. These are not accidental. These are not incidental. So I would actually also suggest, so one thing is we have to raise awareness among very broad range of people. Today, 99% of people in India don't know that IFC has such a major role in all these, you know, big corporate hospitals where they cannot even set foot. And if they set foot, they'll be probably indebted for life. So people need to know about it. But probably even in the US, I mean, the book you have written is excellent. And capitalism on steroids is something which I have been telling people. That's where I got my idea about the elephant on steroids. So, so that is excellent. But we need to reach out this message to far, far more numbers of people in the global north and also in the global south. And secondly, I have a very concrete suggestion for Mr. Raju and their team. Welcome to India. We will organize a multi-stakeholder consultation on IFC-funded private hospitals. You just have to come with your team. We'll do everything else. But it has to be a genuinely open dialogue. And of course, we'll invite the managements of all these hospitals, Apollo, Max, Fortis, Sahyadri, everybody. They will be most welcome to come, but they should be willing to listen and they should be willing to respond. And not just IFC, but the World Bank Group should be involved. Because otherwise, you know, this compartmentalization that IFC is not responsible for regulation, we've been hearing this. And I understand IFC as such may not be having a mandate for regulation, but at World Bank, which is coming, when you come in with money, you come in with responsibility. You know, you cannot come in with money and then say we don't have any responsibility. When you come in with huge funds of hundreds of millions of dollars, there is a responsibility to ensure or at least work with our governments for regulation. You can say that unless you regulate, we won't give more money. That choice is with the IFC. That choice is there with the World Bank. So let us have a dialogue. Maybe it also in Kenya and other countries, it may be possible. Let's start with India, which is the biggest, you know, whatever recipient of IFC funds. And as the People's Health Movement India, I can assure you, we will mobilize across the country and we want positive change. We know we have to live with the private sector. We are not wishing away the private sector, but this elephant has to be tamed. And let's tame this elephant together. Otherwise, it's going to wreak havoc with the kind of steroids that is being given.
Thank you so much, Abhay.
A quick point on that, just a clarification. When I said regulation is not our responsibility, what I meant was the regulation in terms of, let's say, suspending the license of that provider in, doing something wrong, which is not in line with, good clinical practice or patient care, that regulatory power IFC or the World Bank doesn't have it. That has to come from the local regulatory body, whether it's the Department of Health or the Ministry of Health. That's what I meant. Thank you.
Okay, thank you. And thank you for the great questions. I would now like to give our panelists just a quick opportunity for a 30-second final word. Mercy, I'd like to start with you. I feel like Abhay's already had his final word, but Mercy, Gretchen, and Raju will come to you.
Thank you, Maaza. I just feel that I need to talk about this whole thinking around regulation, because when you say that the responsibility around this regulation is not IFC's, is not World Bank, is for these countries, the governments to put in place their regulations and enforce. But there's a reason why they're called third world. There's a reason why they're categorized as low-income countries, because they lack resources, they lack capacity. So let me talk about enforcement of labor standards in Kenya. It's public knowledge. If you go to the Ministry of Labor website, you will find that the Ministry of Labor is the least funded ministry in Kenya. The Inspectorate Department is severely understaffed. Nairobi, again, that has a population of 5 million people, has only 2 labor inspectors. These labor inspectors are, responsible for ensuring that labor standards are not just maintained in these hospitals. They are maintained across the board in every workplace in this city. And so if you do your due diligence, this is public knowledge. How do you then say that you're not responsible for regulation? What did you do when you're taking, into consideration your standards, because you have set them and you're taking? So as Abhay has said, you have the choice to put your money there or not put your money there. And why are you putting your money in under-regulated, poorly resourced, countries where enforcement of these standards is almost impossible? Why are you not investing in enhancing the enforcement, then moving on to these other investments? So that's what I feel. But as everyone else has said, the position of health workers in Kenya, the position of health workers in East Africa is that public health care is what is the right prescriptions for the ills that bedevil our healthcare system. And if anyone is coming into this space of healthcare to support healthcare, to support universal healthcare coverage, we would like that support goes towards strengthening our public healthcare systems. Thank you.
Thank you so much. Gretchen, we'll give you a final word, and then Raju, if you can follow. Thank you.
A final word, that always sounds a little bit, final. So to your point about people do not understand that this is happening. I think people are starting to understand in this country that this is happening. You're just seeing more awareness of the private equity infiltration into healthcare. I like to think that maybe their incursion in the industry, because it is life and death, may just be a bridge too far, because people are going to understand that it is just 180 from where we should be going. That's for starters. The second thing is the market, the interest rate environment is having a definite impact on these companies and on their business model. And that is something they understand. You're starting to see more bankruptcies with these very heavily leveraged companies. And so perhaps the market might do us a favor here by getting rid of some of these entities and in the restructuring, they jettison the debt, but let's get private equity out of that as we see many bankruptcies. I don't know, but that is at least somewhat of a silver lining in the cloud.
Thank you, Gretchen. Raju, please.
Thank you. I think, apologies for repeating myself. I think my key takeaway or my key message is that it is not one party can't solve the problem. It is not a quick fix. It is, I'm not saying there is no issues or challenges there. Definitely. The best way is to come together, and please continue the feedback from, whether it's Oxfam or any civil society. Please continue that feedback mechanism. Let us work together and put an action plan and towards a common goal, because I think I don't think we differ in our common objective or the goal, what we want to do. It's not public versus private. It is a combined effort. Thank you.
Thank you, Raju. Abhay is being very cheeky. He's saying that he would like to have a fine. No, he's shaking his head no. Oh, you have an announcement. Yeah? No, you go make your announcement and then. Yeah.
Well, it's not exactly an announcement, but basically adding to what Rachel said. So of those of you here who may be interested in working further on this issue, tomorrow morning we are having a meeting of civil society groups who are involved in, accountability of, private financing issues. So maybe Anna can add to that, or Harry can add to this. Some of you have already received invitations for this meeting, and some of you have confirmed, but if there are others who are interested about further collaborating, exchanging, then you're, welcome to contact us, and maybe we can give you the details after the meeting is over.
Thank you. So yeah, no, just final word from me would be that I think we need to make sure that the IFC can't dismiss our evidence and the growing evidence base since we published our reports as cases of a few bad apples or anecdotes. I think there are systemic problems here. There are systemic patterns of investments in inaccessible, under-regulated hospitals that need to be addressed, and we need to see a much bigger scale of response than we have. This isn't just feedback. This is urgent. These are lives that need protecting, and we need to prevent more harm. What we've heard today from our panelists is the human impact of a flawed and dangerous approach by the IFC to commercialize and financialize healthcare systems in lower income countries without adequate safeguards and in dangerously under-regulated healthcare sectors. We can't just blame poor government regulation and continue to invest anyway and say it's not our fault. We should have rules that say if the market is under-regulated, if these abuses are widespread across the country, then don't invest in that country in private healthcare. That should be categorical. And I truly believe that today we've only heard the tip of the iceberg. I have absolutely no doubt that there is and will be more harm, more scandals, and there absolutely needs to be more investigations to identify these. But we don't need to wait for those. We already have enough to act now. There can be no excuses and no half measures and no further delays. We need to see a halt to these investments, a full and independent investigation, and full remedy for those who have been harmed. Thank you.
Thank you so much, Anna. Yes, feel free, please, to give a round of applause to our wonderful panelists. Thank you. Thank you, everybody. Thank you for all the great questions. Before we go, I wanted to just give a shout out again to the university that hosted us here today. Apologies about Gretchen's book not getting here early enough for the early people to get it, but I know that addresses have been jotted down. I want to thank Oxfam International, particularly the IFI team, for organizing this and having us here today. Major shout out to Harry Bignell. We would not be here without Harry. So thank you so much for single-handedly getting us all here. We really, really appreciate it. Thank you to Oxfam International for having me and for this wonderful panel. And, just to echo Anna's thoughts and emotions on this, really all our solidarity to the patients and their families whose really devastating and traumatic stories have been uncovered by journalists and researchers working on these stories. I know that it was really, obviously most difficult and harrowing for the people going through it, but also really difficult for the people doing the research. And yeah, my wish for all of us is that we all continue to really work towards a world that's more equal and just, and where healthcare really is a human right. So thank you very much for coming.